Hello, gentlemen. How are we doing
Hey.
today? We've got quite a few folks today.
Great. Hey, Frank.
We're ready. Hey, Frank.
Hello, good to see everyone. We've got a few Michaels on the call today, which is always exciting. If we can have multiple as many Michaels as possible, I think is the goal. But our guests today were dressed up a little bit more formally than our team here, and so as we're waiting for more folks to join, I just wanted to let everyone know that I found a blazer and put it on, and thought about putting a little pin on it as well to be even more fancy. But the only pin I can find is a miniature pin of a Blockbuster VHS tape of Back to the Future Part 2. And I thought, you know what? Not today. I've already put a blazer on. As you can see behind me, I'm pop cultured, so I have enough of it happening around me.
Yeah, you don't want to overdo it. Fun fact about Frank, oftentimes he'll change his artwork behind him depending on the theme of the guest. So last session, we interviewed the former CEO of the Houston Zoo, who's also board chair of a large health system, was an executive in a bank, talking about high reliability and all those. And he had the Lion King behind him. So
we would have loved an Avengers something, but the Mickey Mouse thing, I think, is appropriate as well. Yeah.
I can make that happen. I've got quite a few Avengers pieces. I've actually got my Black Panther piece right over here to the side. You can't see it here. Let's see if I can. There it is.
Oh, there we go.
Yeah. All right. Well, I think it's time to get started. I think we can jump in. It's been 2 minutes, and I wanted to welcome everyone to our Reliable Leadership webinar series. During these events, we have the founding partners of Relia Healthcare Advisors, Dr. Rod Brace and Dr. Michael Shabbat. They're joining me, Frank Dana. I'm the director of culture at Softway, as we get a chance to connect with leaders from a wide variety of industries about reliable leadership, high reliability teams and organizations, and what it takes to build reliable, inclusive, and zero harm workplaces and cultures. So today, we have some very special guests. These gentlemen were at the epicenter of the COVID-19 outbreak in New York City last year, and I wanted to introduce them. The first is John, so John Sendak, and the second is Michael Gitman. So welcome, gentlemen, to this Reliable Leadership webinar. I'm very excited to have you. If you don't mind, could you please give us a little bit of intros in terms of who you are and the work that you do?
Sure, Frank, and thank you very much, and thank you guys so much for having us. So I'm John Sendak. I'm the executive director at North Shore University Hospital, and we're about an 800-bed academic medical center in the New York metro area. I actually took over as executive director, which is our kind of CEO equivalent role for this institution, in January of 2020. So really kind of 8 to 10 weeks before we saw our first patient on March 7th. And it was certainly going to be a test of leadership. And I think we're looking forward to sharing some of that with you and my colleague, Dr. Michael Gitman.
Yeah, thank you, Frank. My name is Michael Gitman. I'm the Chief Medical Officer of North Shore University Hospital. I have been in this role for just shy of 8 years. And in this role, I'm responsible for the medical care that happens in this facility along with John. And I think one thing that may give some context to both of us is that both John and I grew up in the same community where our hospital is located. So we're both from the community, grew up in the community, and have subsequently come back to the community in these roles.
Cool. You know, Frank, I've had the opportunity to work with these gentlemen and some of their team. And one of the things, and part of that work was during the pandemic. And so one of the reasons that they're here as a guest today, I was extremely impressed with how quick they pivoted, how they reorganized, how they addressed the uncertainty of all that. And so certainly we're going to hear a lot about that today in this context. I remind our viewers that if you do have a question for these two gentlemen, feel free to put it in the comments of whatever social feed you're on. We'll be monitoring that. Our producer, Maggie, behind the scenes, will get that out to us, and we'll be happy to address those questions with you. But John, Michael, maybe just to kick this thing off, everyone had their own pandemic experience in healthcare. Each of us had to change the way that we operated. Each of us had various uncertainties and concerns, but maybe just share with us a little bit about the context of what it was like to be in the midst of the pandemic, leading a large healthcare system, large healthcare facilities, and how you and your team responded to that.
Yeah, and I'll start, and Dr. Gitman will follow. I think part of what helps give context is to just begin to understand what the New York metro area is like, and how sort of Northwell Health fits into that. So Northwell Health, which is the health system of which North Shore University Hospital sits as the original institution when the health system was formed, we're one of 23 hospitals, and we sit just a mile outside the New York City limits, and are the largest medical center on the sort of east side of the East River. So in all of Queens and 2 big suburban counties to the east on Long Island, this is the largest medical center, and it's, as I noted, one of 23 that Northwell Health operates in and around the New York City metro area. And I think for us, we recognized early on that we're an institution that has a big mix of surgical and medical patients. And I think in our early kind of phases of monitoring this thing with our health system colleagues, and we began to talk to some colleagues in Italy, which Michael will talk about a little bit. We didn't know for sure that we were going to see patients here, and we certainly didn't know the numbers. I think no one did. We certainly, I don't think, thought New York City would be the early epicenter in the spring of 2020. But I think as we started the planning for this, we treated this like any other emergency management exercise. We're monitoring a storm that's coming through. We're monitoring some impact to operations. We knew early on that what would be different about this is that this was going to be a medical emergency event. This wasn't going to be what we do a lot of, which is weather-related, emergency events or disruption to power, or those sorts of public utility crises that may last a day or two, and is something we have had experience with. But rather, this was going to be something that was going to challenge our clinical capability and our ability to manage patient flow and surges. And this is a hospital that runs all the time right around 100% occupancy, or maybe a few ticks above that. So we are very much accustomed to being full all the time. And so as you start to think about how do you surge a place up, we realized this was going to be a medical operation. And Michael and I had numerous conversations about how we were going to sort of deal with that. So Mike, maybe you want to kind of just take the group very quickly through what we learned very quickly from Italy and how quickly we got overwhelmed.
Sure. So I think we were fortunate in that some of our physicians had contacts in Italy who were really in a hospital at the University of Pavia, who was really the epicenter within Italy. And we had a chance to sit down and talk with them. And, by that time, we knew that beds and ventilators and PPE were going to be an issue. But what was really eye-opening to us is that they shared that 20% of their workforce was out sick. And when they started telling us that prepare for 1 in 5 people not to be able to come to work, that was, jaw-dropping to us. And that really started us, it allowed us to think about what's our strategy. And we're fortunate, as part of a large health system, someone else was dealing with finding the ventilator. Someone else was dealing with finding the PPE. We have incredible procurement at Northwell. And so that burden was lifted from us. And we focused almost entirely on how to keep the staff safe. And I think that conversation early on, before we even knew it was going to happen, really, I think, set us on a trajectory to be able to, of how we were going to manage. And, to answer your question, Rod, it was overwhelming. I mean, going back to March of 2020, now we've been through the initial surge, a second surge, but the initial surge, we didn't understand how to treat the disease. We didn't understand how to keep people safe. And, when we look week to week 1, we had 3 patients with COVID in the hospital. Week 2, we had 30. Week 3, we had 150. Week 4, we had 338. Week 5, we had 627. And then it started to level off. So it was truly a tidal wave that was coming at you, and you just had to wait, and we had to wait till the water receded. And by the end of it, we have about 21 different wards. 17 of them were COVID positive patients. It just marched through our hospital. We were having mothers deliver patients in the hospital, and then we were putting them in an ambulance and having them recover in our ambulatory surgery center. Wow. We were caring for patients in our auditoriums, and the water receded just before we were moving into a tent that was in our parking lot. So it was overwhelming.
That's unbelievable.
Let me ask, how did your staff fare during the pandemic? I share your concerns. Most physicians aren't terribly aware of staffing. I know that our guests today are. When I was in medical school, I served as a nurse manager, an assistant nurse manager at Parkland, and ran a medical ward. And the most difficult thing was when staff called in sick, not a pandemic, but the patients are in the bed. They're already there. They've got to be cared for. How did you manage with your staff, some of whom must have become ill?
Yeah, and I'll start. And I think we were incredibly fortunate in how the hospital is set up, is that we have probably about 4,000 credentialed physicians that are in the area. Not all of them come to the hospital, but we have a lot of physicians. And Northwell Health is a large healthcare system that has a lot of ambulatory practices. So I think that set us up to have the people that we could bring into the hospital. The other thing that I think we were very fortunate about is that many of our physicians, like John and I, live in the community. So this was personal to everyone. This was our community. They were our family. They were our friends that were being admitted. So we really didn't have people that refused to come in. I think we had providers that were scared. You had providers that were doing outpatient work that were now being asked to come in and manage the disease that we didn't understand. And so we wound up, and it took us a little while to scope this up, but being very deliberate on how we oriented people. We had to tell them where to park. We had to tell them where to get scrubs. We had to tell them who they were caring for, and we had to share the protocols for how to treat them. So by mid-March, we got pretty good at identifying where our needs are, sending out emails, and redeploying providers. But that was, to me, what kept me up at night. People don't understand exponential growth. They don't understand going from 300 patients one week to 600 the next, and what that requires as providers. And trying to get through the inertia of redeploying those providers was really what kept me up at night. But when we deployed them, they came to work.
And then I think the other thing that we did that was important early on was we mobilized the next level of management in this institution. We turned around to the level of management below the executive team and said, look, this is yours to operate. We're going to be here. This is yours to operate. And we're going to focus on creating a sense of calmness as leaders. We're going to create a sense of we're making decisions. We're going to communicate very often with as many people as we possibly can. We're going to be present. There was a number of kind of bad media stories of some of our colleagues from other organizations in the greater New York metro area, who were not at work or who left town in some cases and were holed up at their vacation homes, and that got exposed in the media. We knew early on that was just not going to work out for us. We all were worried about exposing each other, and so we took great pains to keep ourselves separated. And we knew this was going to be a war of attrition, right? That we had to keep as many people safe and at work as possible, but we had to physically be here, and we had to get our next level management below the executive team, but above frontline, leadership, right? Leaders of leaders, to lead the organization from an operational standpoint. And our focus as executives was make the decisions and move on, make the decisions and move on, make the decisions and move on, and then be very present and be out there so that people understood that we saw what they were experiencing and we weren't running this thing from an armchair somewhere. And I think that those things early on, to Mike's point, gave everybody a certain comfort. And our corporate CEO, similar thing, stopping on site, checking in with the staff. People want to see their leaders in situations like this, and I think Absolutely. That gave everybody the momentum to come to work and treat this as something we just had to get through.
Remarkable.
Yeah, and the only thing that I'll add to that is one thing that John and I were very thoughtful around is that as the media stories were coming out, it felt as if providers were being victimized by the pandemic, forced to care for patients that were sick. And I think what we realized is that, we were going to make sure people understood that we're not victims, we're heroes. This is what we do. This is who we are. And I think we were very direct with that message. And I think it resonated within this hospital that people were proud of what they did. People came to work because it was a calling and a responsibility.
We saw several media reports here outside of in other parts of the U.S. of people lining up saying thank you to the workers, people showing up with food and, the signs that you are heroes, the term that you used, Michael. Did that wear thin after a while? I've always wondered how, it seems like it would be energizing at first, but when you've been down in the trenches for weeks and weeks and weeks, curious as to whether it wore thin, and if so, how did you keep them propped up, energized, highly engaged in their work?
Yeah, I think it does wear thin, Rod. I think it helped us deal with the initial fear of, coming to work and potentially getting ill. And so being a hero, I think, gets you through that. I think being a hero for 18 months gets you really burned out. So I think we transitioned the message relatively early on. Once we kind of got through that, and to your point, we had, the fire departments, we had the police clapping us out, we had people bringing food. The community energized us and really thanked us and kept us going. And then I think that message transitioned through the second surge and now. And the way that we've brought this out to our teams is that this was a sprint during the initial surge that turned into a marathon getting ready for the second surge, that now we are actually turning into a relay race. So when you're on, you're here working, but you're going to be able to tag out to somebody else. And so we've tried to be very deliberate about changing that message, because I think, to your point, that you can't be a hero forever.
Wow. I'm interested to know, as you were in the middle of this, like you said, this exponential growth, the situation that's happening in the moment, what was most surprising about what was required of you as leaders during this time? What surprised you as a result of this new pandemic springing up?
Yeah, I think from what I remember most about it was fast-paced decision making. I think oftentimes we like to be able to spend at least a moderate amount of time getting as much information as we can and try and make the best decisions we can. We try to use evidence to support decisions. And, Rod, I know you and I have talked about the fact that there's some times where you can use this sort of burning platform as a way of getting people to do what it is that you want them to do. But what we teach everybody is that's very short-lived, and that's not always going to work. And I think we're so used to running emergency operations in our medical centers, as I noted, based on a storm that comes through, again, a momentary disruption in public utilities, things that bog down the organization, and then you go into recovery relatively fast. But this was the sort of thing, as Mike described, you look at those patient load increases, this was like the tabletop exercise that never seemed to end. Like, you wanted to cry uncle. And so at that point, you have to be able to make decisions with, a certain amount of information, and it's got to be good enough. And I think as leaders, that is very different than any of us have experienced or used to. I don't care how much experience you've had or how smart you are or how well-versed you are. I just think that in and of itself is just a very different element of our leadership qualities and skills that I think neither of us, had fully anticipated or necessarily been ready for. Mike, other thoughts on that?
Yeah, I agree 100%. And I think the other two thoughts I have on that is, one, how quickly we had to change tactics. So we had done planning before this happened. And we were going to put the patients in a particular unit. We got our first patient. We walked up that unit. We realized we don't have doors on that unit, and it was open curtain. So the first decision that we had was wrong. Wow. And we had to kind of change. And as a health system, we had decided, listen, we're all going to manage in place. We're not going to do a lot of transferring patients. Every hospital is going to manage it. And then what we realized is that was not the right strategy, because we had very dense populations near our smaller hospitals, and they would get overrun, and we had to move patients to the bigger hospitals. So we had done a lot of planning, and just about all of it had to be changed almost at the very start of this pandemic. And the other thing is leadership style. Both John and I tend to lead more democratically, get people involved, help make a decision, empower others to really try to run different areas. And this was much more autocratic leadership style because you were really leading through fear, and people wanted to see a decisive, strong leader. And what I personally learned from that, because that is not where I'm most comfortable, is we were in that mode for a year, and it's one of the more lonely leadership styles to have. You're taking a lot on your own shoulders to try to deburden other people from having some of those responsibilities.
Mm-hmm. John, you made a just sort of fleeting comment a while ago that it doesn't just happen by magic. You said we met with sort of the middle managers and directors and said it's your organization to manage now. That too, in some organizations, could be disastrous. But it sounds like you all had already a very high level of trust. You had already prepared those leaders, perhaps for maybe not the full reality of this, but having that autonomy to lead the organization. I just, if nothing else, I wanted to make that observation that was very impressive that you all took that move.
Thank you. What I'll tell you about that, and I noted that I took over really only 8 weeks prior to the organization of March 7th, so it wasn't like we had a huge ramp. But what I didn't note is that I had been here in the second in command, the kind of COO role here for a number of years prior. And one of the things I was very interested in, and Dr. Gitman and I worked very closely on for a long time with the rest of our executive team, was, in order for the executive team of the medical center to be able to focus on strategic initiatives, you can't be doing daily operations. And I think one of the things I had worked at some of Northwell's smaller hospitals previous to this in a lead finance executive role, and in some of our smaller outfits, because of just the less number of management level folks, we did tend to be much more involved in day-to-day operations as executives. And when I came to North Shore, I noted that, it's going to be important. We have this great group of people in management who we should be able to say, hey, if the 8 executives on this team went to a week-long conference together, which we never do, we should be able to not have to think about operations, that we should be able to have a team. And so we had been having that group for 3 years of people at the level, again, below executive, but above department head, meeting as like a replica of us. So when we'd have our executive meeting, they'd meet in another room as a group. And then once a month, we would get together with them and say, what are you all talking about? What are we all talking about? And to get them to feel you're like you're the backup, and ultimately you're the primary. That's where we wanted to shift to. I think that served us very well in this particular case, because people here feel they're like, hey, just let us take care of it. And I personally, as we look back, I didn't realize it at the time. I thought, well, we're going to see. And in my personal life, one of my hobbies is I'm a pilot. And one of the things, that comes up in aviation a lot, is we brief a lot of things. And when the emergency actually happens, you say, well, we've been briefing this, so I hope that, this is going to happen the way that we've been talking about it happening. And I was really delighted the way that group stepped forward. And we'll probably get to this later in this webinar, but now that's set this institution up differently for the future. Because now those folks have had an opportunity to do something that they got to demonstrate. This wasn't like a capstone project for some graduate course. Like this, they did it in real life. And so now they don't want to give it back, and I'm fine with that, because there's plenty of stuff for this institution to focus on from a strategic growth standpoint and other strategic initiatives that we are very happy to now be in this slightly different position with that next level of management. And I think I think it's worked out very well for us, but we didn't know. And I said, well, we're going to give it to them, because we all going to need to be present and visible. And as Michael said, making autocratic decisions so people know there's someone in charge or there's a few people in charge. And then every week, Dr. Gitman and I sent the correspondence to this entire medical staff and medical institution, 6,000 or 7,000 people, said, here's where we are for this week, and here's where we're going. And we tried to keep it as optimistic but realistic as we possibly could.
Lots of great tips in there.
Yeah, and I agree, Rod. You know, being able to manage this was dependent upon our middle management, them understanding that they were going to have to get staff comfortable. We were very clear early on about there's no help coming. So we're it. So let's figure it out. And two, we're going to be uncomfortable. We're going to be managing patients in non-traditional areas. We're going to be stretched at ratios we've never done before. So, you know, get people prepared. And we started that almost from the very beginning. And
when we started building the tents in the parking lots, we put people in golf carts and drove them out there and said, this is where you're going to be taking care of patients by Friday if these numbers keep going up. So just react to it now. Start telling us what you need. You know,
react to it now.
I remember I saw Mike putting some doctors on a golf cart. I'm like, where are you going? He's like, these people are going to have to work up there. I got to take them up there now and show them what it's going to be like. It's not going to be me and you, you know, and that's what people appreciate is, you know, they understood it, but it was becoming very real. And comments like Michael said to people, look, there's no help coming. You know, we didn't want to frighten people, but we also don't want to get this idea of false hope. I think is very dangerous when people are frightened. I don't think it helps in any way.
Well, let me ask a question. New York as a state is a highly regulated state. And I wondered, were there any initial or eventual governmental or regulatory barriers that you had to get beyond? It's not so easy to add beds in a parking lot usually.
Michael, you want to?
Yeah, I think, you know, a lot of the regulatory, I think, hurdles within this was getting data to the state about how many beds you have, how many patients you have, what are your surge capacity, where are you having the next patients, what's your testing process. That was a lot of work. And I think where John and I were incredibly fortunate in that our health system took that on. So it wasn't necessarily the hospital's responsibility. They took that, which was a huge amount of work and time. And they did that for us and for every other hospital. So we were really deburdened with that. I think where the state really helped us is that they allowed us to load balance during the first surge and the second surge, meaning that we were able to move patients. We consented many of them, but without their consent, if we had to, from hospitals that had no capacity to hospitals that had capacity. And that saved, you know, numerous lives being able to do that. And then I think the state actually decreased a lot of the regulatory requirements we had around documentation and other things around credentialing to make sure that we could get providers in rapidly. So I think the difficult part was all the reporting, which we were really burdened of. And I think they made a lot of decisions in New York that made a lot of the care, I think, easier.
Yeah, I don't have anything to add on that. I think exactly what I was going to say, which is the benefit of being part of a big system was that we had terrific people who were managing getting that data up to the state and really working with the state to do the right thing for the whole state. I mean, Northwell Health is the largest healthcare provider in the state of New York, and it's also the state's largest private employer. So we're very fortunate in that you know, you think about New York State with New York City and all that stuff. We're fortunate that, you know, we were able to work closely with the other big systems in the New York City area, and then together we're able to really collaborate on how we were going to kind of work with the state to make this make sense. And I think that us as executives of an academic medical center that was under stress, not having to spend time on the calls related to that was incredibly helpful.
And I think there's some credit due to regulators and Joint Commission and others that really saw that they probably don't have the immediacy of what's going on in front of them. They don't have the answers. And so they really turned it back to the operators. And so, you know, in some sense, they should be applauded for that.
100%.
A quick follow-up. The load balancing, was that all within the Northwell system, or was there load balancing among the different hospital systems, you know, in the city and in the state?
In New York, it was mostly within Northwell Health, although we had the ability to move some patients to the Javits Center, which the state had run, and some other centers, and we took some patients from other hospitals, but the majority of the load balancing was between Northwell hospitals, and we, as John said, have 23 of them. And what we saw initially during the initial surge in March 2020, we accepted, hundreds of patients from other hospitals. As we transitioned a year later to our second surge, the strategy was very different. What we had done is, as John had said, during the first surge, we emptied all the surgical services in this hospital and filled those beds up with patients that had COVID. During the second surge, what we wanted to be able to do is continue to provide those surgical services because, as everyone knows, people died at home for not getting the care that they would otherwise have gotten. So the strategy was within Northwell was that North Shore is no longer going to be the site that accepts all the patients from other sites, but North Shore is going to be a site that, when necessary, sends patients to other sites to be able to continue to do the surgical work. And so we actually lived both sides of that load balancing. On the initial surge, we took a lot of patients. On the second surge, we moved some patients out of here.
And just context for our viewers, that switch from a hospital, purely COVID, it was quite staggering for you guys because you're the regional quaternary facility, and so patient's not a patient. You're not equipped for that sort of level every day, and so I suspect there was some tremendous shifting of activities and mindsets that went on. In the midst of this, I did have the privilege to sit down with John and Michael and their team on a little bit of a roundtable with their C-suite. And one of the things I was very impressed with is they took the approach of, okay, there's 10 people around this table. They're leaders. A couple of weeks ago, a couple of months ago, last year, they all had very specific roles and they knew their duties, but today they're leaders. And so now they took the approach of a best player, and HR was doing things that weren't HR. But maybe talk a little bit about how this shifted roles and accountabilities during that, and strategically how you approach that.
Yeah, no, I think that's exactly right. I mean, I think we basically said, look, everyone's work is suspended. So we took our finance exec and our operations exec, and we told them, you're interchangeable. So stick together, and you're going to go and cover a piece of this. Dr. Gitman and I'm not a physician, but we were interchangeable. We took our executive in charge of patient safety and quality and our chief nursing officer and said, you two are interchangeable. And then we did the same thing with HR and our perioperative executive. And so we kind of divided up like that. And when I say interchangeable, the idea was if we get to the point where we have to have an A team and a B team, where one group comes to work for these days and the other group comes to work so we don't cross-contaminate, we're worried about one exposure could wipe out the entire team. And that did happen in other parts of our organization early on, where, literally it was the first day of the war, and all of a sudden, a bunch of our own people in management in our organization got sick. Exactly what Italy told us was going to happen. We're like, oh my God, by the time we realized it could happen, like, you almost don't think it could happen to you. And you're like, what the hell are we all doing, even with masks, being around each other? So, we immediately started looking at it from a backup standpoint. And then we looked at it from a cross-functional standpoint to give people the opportunity to work outside their areas. And it's amazing. I wish I could do it in real life. We started to look at people differently because, let's face it, I mean, most of our people in roles on our executive teams, I was a finance executive in one building, but I was the operations executive in another. Like, most of us have areas of expertise, but we're generalists ultimately, and so that became real clear in this case. And it blurred the lines a little bit about, I'm the VP of this, I'm the VP of that. It just turned out, I'm a member of the executive team. And I think that for our group, and you witnessed it a little bit, Rob, when you met with us, I think that changed people's identity a little bit to be seen a little differently than just, I'm a member of the team who has primary function of X, but now that we're in this thing, I'm just a member of the team, and whatever that is involved in that is involved in that, because everyone has similar academic backgrounds. And so, I think that has worked, other than the medicine stuff. I think
so Dr. Gitman, were there similar dynamics among physician leadership roles?
Yeah, I think absolutely. There were a lot of problems to solve that were all happening simultaneously. And what we realized early on is that there were some people that were kind of on the sidelines. You had ED physicians working incredibly hard. You had ICU physicians working hard. You had hospitalists working hard, but we weren't doing transplants anymore. we weren't doing orthopedic surgery. And so it hit John and I early on that there's a whole bunch of people that are really good problem solvers that we have to leverage. And so what we would do is that we took our vice chair of surgery, who's in charge of our transplant program, and say, well, you're not transplanting patients, so we'd like you to take on employee safety, and you're going to run it. And so figure out what it is, figure out what we have to do, but you're in charge of it. I took our chair of orthopedic surgery. I said, you know what? You're running the ORs. I was like, I don't have time to do it. You're doing it. You're my designee. Figure out what has to go to the OR, what can wait, and figure out that process. We had a problem with how to get patients that were waiting a COVID test result in our ED bedded. One of the management principles John and I had is that we're going to keep our ED empty, because we felt if our ED was on fire, that is going to change the dynamics of the hospital. It's going to feel disorganized. It's going to feel unsafe, and we needed it to feel safe. So we took a couple administrators that weren't doing much, that were in orthopedics, and said, you're in charge of it. Fix the problem.
Right, get down to the ER.
And report. And they were there overnight bedding patients. And when we came in the morning, there were no patients waiting for beds. So we use non-traditional workforces. We realized that we have a lot of talented people that can solve problems, and we just put them in charge of different areas and allowed them to solve it and report back to us how they were doing it.
Well, I've got a follow-up question now. So, you know, the overflowing ED is the bane of every acute care hospital. So you can't run a pandemic. You can't have the orthopedic chiefs, you know, running an ED bed flow permanently. But how do you take the, quote, lessons learned, end quote, from how things ran during the pandemic toward non-pandemic times? How do you keep that ED empty?
Yeah, and I'll start. And I think some of the lessons that we learned was alignment and prioritization. So during COVID, it was very interesting that there was only one priority. And so it was easy to get everyone on the same page about what to do. And so we learned, I think, a fair amount about prioritization. And I think we also learned about accountability. So we set up meetings, you know, early on. They were on multiple times a day, where we would go through a checklist of different initiatives and ask the people in charge of it, where are you? You know, what's the next step? How close are we? And so we really developed an accountability around different initiatives. And that we've continued to do. So we continue to have a situational awareness meeting on Monday, where we get everyone in the hospital on a call at the same time on a Teams meeting, where we go through where we are in different areas and make sure that we're all aligned. And then we've come up with a strategic initiatives meeting on Thursday, where anything that we're working on, we go and get updates from the people in charge of it. And it's really a much more fast-paced way to bring about change. And you know, one of the things that allowed us to do that is that we adopted a digital platform. So it used to be very difficult to get everyone in an auditorium together. People are in different sites and they can't get there. You know, now that we do it digitally, you know, these meetings are down to 15 to 20 minutes. So we get the whole hospital aligned twice a week in 20 minutes, which is something that we were never able to do before.
That's a great observation.
You know, talk to us a little bit about the state of the team now. And so obviously going into the pandemic, healthcare professionals were already experiencing high levels of burnout. Their concept of moral injury, that not being able to right a wrong that you see happening to you, all became very real as people would show up at facilities and there just weren't beds, there weren't you know, PPE, whatever it might be. Talk to us about what you're seeing now in terms of the prevalence of burnout, moral injury, and then perhaps your thoughts on how we move forward with those conditions, not only at your facility, but just nationally.
Yeah, I'll start with this, and I'm sure Michael will have quite a bit to add, because we spoke about this a lot, and as Michael said early on, I mean, we sat and had a very deliberate discussion about we're not going to be victims, and I think being very deliberate about what you call yourself and how you relate to it is important. So when all this stuff starts coming out about burnout and how people react, we too were very concerned about that, and we've done a tremendous amount of work through the pandemic to continue to take very active steps to tell people we have resources to support you. We put all kinds of respite tents up where we had staff there to meet with employees, not necessarily for counseling, but to do certain activities with them. We did a lot of art therapy. We did this thing on a wall where you came and threw paint at it as kind of a to kind of throw paint at COVID. I mean, we did stuff that some people might find hokey, but our art therapist thought would be good, and I couldn't get over the number of people who lined up to do it. It became clear to me that people needed that sort of release to do certain things. And we kept orienting them to the community support that we had. But as time went on, it becomes a long slog. And I think that's all these things, you talked about what wears thin, all these things start to wear thin. So one of the things we started to talk about was we need to encourage people, because people felt incredibly guilty, about their inability to save as many people as they could. They felt guilty about the way the outcomes were, for some patients. I mean, there's just a lot of that stuff that was going on. And so one of the things that we tried really hard to do was to play up all the successes as much as we could to orient people to that. And then separately to say to them, we need an organized process here for how we're going to encourage people to take deliberate time. I think people started to feel guilty about taking time off.
Yeah.
And so we forced it, not by making people leave, but we came up with a bit of a theme, because what Michael and I quickly determined was, if we don't write the narrative on this, other people are going to, meaning someone's going to start to want to run a campaign in the hospital for all these. So we said, where we think we are with this, and we looked at some of the survey data. Our survey data came back on our employee engagement in the highest percentile it's ever been. Which in the upper 90s, which for us, wow. we were like really taken back. We jumped from the 82nd percentile, to the lower 90s, to the 93rd percentile nationally in employee engagement, in the fall of 2020. So we were like, wow. I mean, people. So wait. So are they? How do they feel about working, or how do they feel about their career? How do they feel about this line of work? We weren't seeing this massive excess of people trying to leave healthcare. We were in a relatively good spot. So we decided we need a campaign, and we really started to push it. We came up with a bit of a marketing term for it, but something along the lines of relax, relay, recharge. Meaning, we Mike, because of his focus on marathons and his obsession with personal fitness, came up with this idea that this is going to we're going to keep jogging, and so, but we don't want a situation where people take breaks. We need the place to keep moving, and so we positioned it as hand off, with the baton, and then you take your break, and then come back ready to go. And the reason we thought that was important was we were in a phase, particularly with management, where people are like kind of working from home, they're kind of working from work. Every week felt like it was a bit of a light week. Meetings weren't being scheduled, but there's still a huge amount of work to do in our hospitals. And so we really started to force this idea of when you're here, and when you're off, you're off. Because the other thing, obviously, as many of you know, this blurry line between when you're working, you're not working, you're working from home, do you still take meetings, even though you're off? I mean, it just got to the point we just said, we need to get this, even if we're not meeting in person, when you're at work, we want you to work. And then we want you to relay to somebody else, say, you're covering me for 2 weeks or whatever it is. And then we want you to be off. And then come back and relay it to someone else. And we think that really, people embrace that. And we T-shirts and bumper stickers. And we really tried to push that idea for people. And I think what that did was get people to say, it's okay to do it. And we then had to do it ourselves, which was the last part. As much as I told you in the beginning, the executives need to be present, we weren't taking time off either. We felt guilty, I think, as individuals. And it wasn't until we started to say, I'm out that week, that everyone else around here said, well, okay, I guess it's okay.
We have permission.
Yeah, right, we have permission. Mike, were you going to say something?
Yeah, the only thing I would add is just understanding how this was pushed by the digital platform is that, there, not only do you have an ability to go to a meeting wherever you are, but there almost felt to be that there was an expectation. And so I think Teams really helped us communicate and be, get the message out and really manage, I think, highly complex things. But I think on the back end, being available constantly and feeling that expectation really is what I think drives burnout more than anything. And we try to make very deliberate rules about, when you don't go to the meeting.
Yeah.
Wow. I'm wondering, in regards to where the medical staff is today, how did the pandemic make your teams or individuals more effective as a result of experiencing this pandemic? What are some of those trends that you actually saw within different groups from a wide variety of perspectives within the organization? But I'm wondering, what are some of those things that you saw from an effectiveness standpoint?
Yeah, I'll start. We had put together a structure, because as John said, that we're an overcrowded hospital. So we really have to push efficiencies. We have a medical staff that is partly community physicians and partly employed. So you have a lot of control over some of them and less control over others of them. And so over a 3 to 4 year period, what we had been doing were putting physician leaders to partner with nurse managers on editing in their kind of administrative career. And what we saw is that group really took ownership of a lot of what we did. And they provided a lot of stability for us. And, I'm a medicine doctor, so I'm a nephrologist by training. And one of the things that I certainly get a lot of satisfaction about is that in this hospital, we talk about neurosurgeons, we talk about cardiothoracic surgeons, we talk about transplant surgeons. That's what we focus a lot on. But the people that stepped up were not only those people who did as well, but these were hospitalists. These were medicine doctors, and it really, for us, and what I love about it is it showed the importance of people that are typically lower down on the pecking order, within our hospital. And I think what I see now in our medical board, in our meetings here, those people are empowered and feel like they're on equal footing with take your pick of, whatever subspecialist surgeon they are talking to. And I think it gave people a seat at the table that didn't feel they had one in the past.
Yeah, wow, absolutely true. And I think we describe it as where we think the medical staff is now, as well as the management team here, is agile, opportunistic, and optimistic. I think those are the words that Michael and I have been throwing around to describe where we think people sit today, comparatively to 4 years ago.
And I will share one anecdote is that as we were kind of coming down the first surge, and it was clear that we were going to get over the hill, and we were going to be in a better place. We were giving different providers times off from the ICU just to make sure that we're tagging and tagging out. And it was brought to us that our cardiothoracic surgeons want to run one of the COVID ICUs, which is not surprising to me. But, I realized, and John and I had talked about it, that we hadn't had a physician get sick. Or get severely sick, nor a nurse. And knock on wood, we're fortunate that we didn't lose any employees during this. And we thought that the one thing that could really cause a lot of moral injury in this hospital is if one of our true leaders, one of our real physician leaders were to get sick. So I went into our chair of CT surgery and I sat down and we closed the door and I said, Dr. X, I said, I appreciate that you want to run this unit, but our medical staff would fall apart if they knew you in some way got injured. And I said, don't do it. And he cursed at me and told me to get out. And
yeah.
and
with the F word.
And so
he dropped it.
He ran the unit and he said, listen, this is my responsibility and I'm going to do it and get out of my office.
And it was Michael, it wasn't just him wanting to run unit. He wanted him and all the CT surgeons to be the critical care doctors taking care of, a 30-bedded COVID ICU. And we were like, this is not smart. And
right.
They would hear nothing of it. It was Mike's. I forgot about that. Michael's absolutely right. They would hear nothing of it.
So what happened?
What a wild
Did
story.
Yeah.
Did it work?
So I got the hell out of his room, and
It was probably their ICU, wasn't it? I mean,
it was their ICU. It didn't have their
It didn't have any heart patients in it, and we were going to have it run by other doctors, and they wouldn't hear it.
But that was a message to the rest of our staff.
Yeah,
that's right.
Everyone participated.
And what our chairman of CT surgery said, Michael, if you remember this, he said, "I got to tell you, I feel more comfortable here than I do at the grocery store." He goes, "I know what I'm getting into here. We have all the PPE we need." He's like, "The staff here is terrific, blah, blah, blah."
Yeah.
He goes, "I get more nervous when I got to stop on my way home to pick up a sandwich."
Come on.
That's
amazing.
A quality-related question for you guys. North Shore has a long history of high quality, and I actually had the pleasure of giving surgical grand rounds there some time ago, a good while ago. And I know some of the measurements were reporting of quality measurements was suspended during the pandemic. But do you have an estimate of what happened to quality and safety during the pandemic? Serious adverse events and those kind of things that we wish didn't happen. How did you fare during literally a battlefield operation?
Yeah, I think the initial surge in March of 2020 was difficult. We had a lot of people with central lines. We had a lot of people needing ventilators. And we were not able to follow our data for March and April. Mm-hmm. But by the time we got back to May of 2020, we continued to monitor everything that we had done and continued to push on the quality outcomes and making sure they're not hospital-acquired conditions or hospital-acquired infections. So we really only suspended that practice for maybe a month or two. And then we continue to push it. I think we're incredibly proud that we moved from a 3-star hospital to a 4-star hospital during that time. So we really, John will talk about it all the time that, our strategic pillars, one of them is reputation and another one is quality. And so despite the pandemic, those are things that we're going to continue to focus on. So as soon as we were able to get through the initial surge, we put all those processes back in place and continued to monitor and address those concerns.
Kudos to you. Of course, Michael and I, in our experience with organizations across the nation, that was not always the case. And some had those in place earlier and suspended them. And in some cases, those are still suspended, not returning to them fully. And so we applaud you for that initiative. I'm struck with, if I'm sitting here watching as a viewer, it sounds like North Shore had a strategy, implemented that strategy, everything worked really well. And, we just referred to the book and click, click, click. Y'all did a lot of great stuff. I was very impressed with how you were handling it. Is that fair? Is that how it happened?
I'll start and I'll kick it to John. And I think the true measure of success is how many lives were saved. And I don't think we did any better than anyone else. And I hope we didn't do worse than anyone else. And I think that's the real measure. And I don't think we know. I think we made a lot of management decisions that we're very comfortable with. But the true measure of success, I think, is lives saved. And I'm certain we didn't do better than everyone else in that.
Yeah, and that's exactly the metric and the yardstick I would use, Rod. I don't think there's anything else that we could say about that. And I think what Mike talked to you about is, look, I know everything didn't go perfectly, right? We told you that early on, a couple of our plans were totally, ill-suited for the mission. And it took us a second to figure that out. I think, as I told you, we had a number of very high-ranking people all get sick right in the very beginning of this, pandemic, that we're like, well, what are we going to do without them? I mean, thank God there was no death, but it was like a jarring thing. Like, it could be you next. All of a sudden you're at the military tent and the two people standing next to you get shot in the arm. I mean, they just fall down. I mean, all of a sudden you're like, well, they're not going to be at the meeting in an hour. I remember when, we knew we thought we were going to have to go into, we have a skilled nursing facility that's used as a short-term rehab, 220 beds on this property. And as we saw the water level continue to rise with patient numbers, the tents weren't going to be ready fast enough. we said, look, we got to empty out the skilled nursing facility. I remember when Dr. Gibman called his colleague, who's the medical director up there in medicine, is a geriatrician, and the guy answered the phone, and Mike goes, very, very directly, the guy says, hey, Mike, how can I help you? And he said, Howie, I need you to empty that place out in the next 2 days. And the guy's like, what? But then he said, Michael, 2 of my doctors just walked out of here shivering with severe fever and body aches. I got to call you back. Like, he was overwhelmed by that couple of his key people were now ill. I mean, it was the sort of thing where, you just had to pivot, I think. And that's, right. So we can never tell you it went by the textbook because there was none. And certainly we made errors, and certainly we things we thought would work didn't work. But I think, like in any emergency management situation, it's about how quickly are you able to just switch gears. And I think in that regard, we did well. The final measure is going to be how many patients were saved. I think we feel we made decisions that saved the most.
Right. Yeah. I'm very inspired by this conversation. And John, you mentioned what came out of this was the ability to be agile. You said opportunistic and optimistic.
Yeah.
And that's really those skills were gathered. And it's interesting to me. First of all, we could keep talking about this for hours. I think that this time just flew by. In discussing this with you, the thing that was so captivating to me, and I hope kept our audience almost on the edge of their seats as well, is we never said reliable leadership at all during this conversation. We said it at the very beginning when I introduced this webinar, but every single topic and everything you described is what we would describe as reliable leadership. The choices that you made, the humility that you show, the creating a sense of calm, communicating, being present, making decisions to help empower others, being transparent in your decision-making styles, being servant leaders. All of these are attributes of reliable leadership. And in just describing the stories and the experiences and the things that you went through, it's very clear that we never had to say it because it was being exemplified through the stories you were telling and the experiences that you had. And for me, it was an honor to hear the stories, and I just personally want to say thank you for the commitment and the dedication and the sacrifice that both of you have made and all medical professionals have made. But I also wanted to ask if there's anything else you'd like to share with our audience before we wrap. Wanted to give you both the final word for anything else you'd like to share with the group watching.
No, but thank you, and thank you for considering us and giving us the opportunity to come and talk about this. I think for us, it's always great to have the opportunity to reflect back on these things, and this gives us an organized way to do that. And I think just one comment we want to make to all our colleagues that are listening or who will listen to this later, is that everyone had an experience with COVID, and I don't think that Dr. Gibman or I think that what we did in any way was more unique or that we had a better solution or that in any way we think we did it right and someone else in any way did not. I think everyone had different challenges, they had different resources available to them, and they had different things that were in front of them. Mike, I'll give you the last word since I know there's only a minute left.
Yeah, no, I that's incredibly well said, John, and I don't have anything to add to that.
Great. Frank, thank you.
Well, thank you both.
Absolutely.
We appreciate it.
Yeah.
Your experience hopefully will continue to be shared throughout our industry. We learned a lot from you guys as we watched. I'm sure you learned a lot about yourself through this. And so it's an absolute privilege and honor to speak with both of y'all today. Thanks.
Thank you. Have a nice day, everyone.
Thanks, everyone, for joining.